This past February, I learned a new word at Academy Health's National Health Policy Conference, VUCA. VUCA, it's not actually a word. It's an acronym that stands for volatile, uncertain, complex, and ambiguous. These four adjectives describe the current policy environment. This includes the health policy environment and policy as it relates to the funding of research and science. This VUCA environment has created a lot of anxiety punctuated with fear, alarm, anger, discontentment, and even despair. Because of VUCA, some of us have even contemplated leaving the profession. As we experience the range of emotions one can have in response to VUCA, I want to encourage us all to channel our energies in a different way. Let us respond to VUCA with hope. Yes, hope. Hope, an expression of optimism about the future despite difficult challenges. However, I'm not just encouraging you to feel hope. Rather, I want you to express hope as an acronym of four nouns that describe our reaction to the VUCA environment. Hope, honesty, opportunity, professionalism, and evidence. In the VUCA environment, it's important for us to respond with honest dialogue, to recognize and realize the opportunities to do good work, to affirm the need for professional researchers to guide and inform policy, and to insist that policy making be based on the best evidence. Why hope? Honesty is important. Too often, the dialogue surrounding health policy debates are filled with hyperbole and apocalyptic predictions designed to scare and anger the public to support one policy over another. Sound bites are easy to remember, they're catchy, shocking, and provoking, and it seems to be the preferred mode of communication. Too often, the public is exposed to so-called health policy experts who engage in what amounts to intellectual name-calling designed to defame a policy proposal of their opponents. We, the health policy professionals, should contend for these debates and insist that dialogue be honest. And when the debate table is sullied with nonsense arguments, which are at best exaggerations, we should have the integrity to set the record straight, even if the nonsense is being used to support a policy position of ours. Why hope? Because even in the VUCA environment, there are opportunities to do good work. We should not forgo these opportunities. We will have opportunities to speak truth to power, to speak up for stakeholders who are at the policy table, and to encourage policymakers to weigh in on all options and to consider the full ramifications of their policies. We'll also have opportunities to advise those in power to do good policy. We may be asked even to serve alongside those in power. In both instances, you will be criticized. It takes courage to speak truth to power. It takes courage to work alongside power. However, we must assess the opportunities, and if we can do good work, we should have the courage to do good work. Why hope? Health policy should be made by professionals, people who are trained and who know what they're doing. Unfortunately, our society has become too accepting of pseudoscience. One of the negative consequences of our ability to self-publish, self-produce, and self-promote is the inability of peer review and editors to edit information that is mass-produced. Anyone with a computer, a camera, or a cell phone can produce what appears to be credible presentations filled with pseudoscience and gain a following. For example, one of the more funniest things I've heard is that there are people who believe the earth is flat. You laugh, but on YouTube, there are many polished videos arguing that Copernicus was wrong and that the earth is actually flat. They accuse NASA of playing a big hoax on the world to receive billions of dollars in tax revenues from the US taxpayer. They accuse NASA of faking the moon landing with the help of Disney and photoshopping the earth, pictures of the earth from space. Now, you and I may laugh at this pseudoscience and brush it off as nonsense. However, people who believe pseudoscience vote for people who cut funding for real science. Hence, we find ourselves in the streets marching for science, trying to convince some policymakers and the public of its value. We must find a way to restore the role of the editor and peer review to the mass distribution of scientific information so that the public can discern scientific findings from science fiction. Finally, why hope? Policy must be informed by evidence. We just can't make it up. This is an answer I often give individuals who ask me to provide support for policies and practices for which there is no real good evidence for. I don't know is a perfectly fine answer. For where I don't know ends, research and exploration begins. Sometimes when I hear policy debates and I listen to the arguments used to support some policy over another, too often I conclude that the so-called expert just made it up. Policy must be informed by evidence, and we must insist that policy be based on evidence and evaluated with evidence because evidence matters. When policy is based on data that has been made up, we must have the courage to point this out even if we support the policy. Because if the public becomes accustomed to accepting data that's made up, then those of us who produce evidence will find ourselves left out of the policy debates. Yes, VUCA describes the current policy environment. This is not the first time, nor will it be the last time. But guess what? This is our time and our moment to respond with hope. Respond with hope by insisting on honest dialogue. Respond with hope by looking for the opportunities to do good work. Respond with hope by reminding policymakers and the public that research is a profession, not a hobby. And respond with hope by insisting that good policy is based on the best evidence. Respond to VUCA with hope. Thank you all. Now it's my pleasure to introduce the portion of our program where we honor the field's leaders. The Distinguished Investigator Award recognizes individuals who have made a significant and long-standing contribution to the field of health services research. These individuals serve as leaders and role models for the field. I want to thank Anne-Marie O'Day, Chair of the Distinguished Investigators Award Committee, and the other members of the committee. Please join me in congratulating the 2017 Distinguished Investigator Award recipient, Dr. John Ayanian. Dr. Ayanian is the Alice Hamilton Professor of Medicine, Professor of Health Management and Policy, and Professor of Public Policy. He is also the inaugural director of the Institute of Healthcare Policy and Innovation at the University of Michigan, where he leads the nation's largest university-based organization of health services researchers, which includes 500 faculty members and 17 schools and colleges. He was previously professor of medicine and healthcare policy at the Harvard Medical School. John is an accomplished health services researcher, producing groundbreaking policy-relevant research for more than 3 decades, publishing 233 peer-reviewed articles and 61 invited editorials and commentaries in high-impact journals, while receiving numerous national awards and recognitions. But beyond this, the award committee saw that John has made a substantial impact on healthcare policy and population health. So join me in congratulating John.
So Daryl, before I begin my remarks, can we be sure this Academy Award's meant for me and not for La La Land?
It's for you.
Thank you. So 19 years ago, I was on this stage to receive the Alice Hirsch Award, like my colleague Julia Adler-Milstein will receive for her accomplishments in a few minutes. At that time, I showed a photo on the big screen of my 3 children, who were 7, 5, and 2 at the time. We were planting our first vegetable garden together, and I reflected on the parallels between starting a garden and launching a career in health services research. Good seeds of ideas, rich soil for collaboration, and plenty of nurturing and patience to give good ideas time to bear fruit. Our kids are now in their 20s, and I'm honored to have my wife Anne and my daughter Caroline here to celebrate this special occasion with me today. I've had the privilege of plowing and harvesting the fields of health services research with superb collaborators at 2 great universities, Harvard and Michigan. I'd like to give special thanks to my esteemed colleagues, Eve Kerr at Michigan and Nancy Keating at Harvard, who nominated me for this award, and to 5 colleagues who contributed to the nomination. Arnold Epstein, who was my original research mentor at Harvard and got me started in this field, Rod Hayward, who leads the Clinician Scholars Program at Michigan, and 3 of my very talented younger colleagues, Amal Trivedi, Michael McWilliams, and Renu Tepernini. We meet today at a time of turmoil in health policy, as Daryl aptly described, with the uncertain future of the Affordable Care Act. When I started my first health services research project as a medical student 30 years ago, I had just finished a course on the plight of uninsured Americans. At that time, 30 million Americans were uninsured, and the number grew steadily to 48 million by 2010. In my clinical work as a primary care physician in Boston, I saw how uninsured patients struggled to pay their medical bills and often postponed or avoided care that could help them, and how these problems were relieved when Massachusetts expanded coverage in 2006. Most vividly, I remember my uninsured patient who was a hardworking, self-employed man feeling poorly with profound fatigue for weeks. When he came to see me a few months after Massachusetts health reform, his blood sugar was over 400. With help from my clinic staff, he enrolled in an affordable private insurance plan. His medications for newly diagnosed diabetes were covered within a day, and his blood sugar was well controlled soon afterward. Within a few weeks, he felt much better and was able to resume working and supporting his family with full vitality. Over the past 3 years, the Affordable Care Act has dramatically expanded coverage, and stories like my patient's experience have multiplied many-fold as over 20 million Americans have gained Medicaid coverage or affordable private insurance. At the University of Michigan, my colleagues and I have been tracking the experiences of the enrollees in the Healthy Michigan Plan, our state's version of Medicaid expansion that covers 650,000 low-income adults. Our Michigan team now has a growing body of quantitative and qualitative evidence, including a number of presentations at this meeting, showing how Medicaid coverage has improved people's health, their financial security, and their quality of life. We are also excited to see at this conference what other research teams from around the country are learning about the effects of the ACA. As the fate of the Affordable Care Act hangs in the balance on Capitol Hill, the need for solid evidence to guide policy will remain strong, whatever direction health policy takes going forward. The rigorous research of many in our Academy Health community helped to make the case for Massachusetts health reform and for the Affordable Care Act. Our work is even more important now. I encourage all of us in Academy Health, both the researchers who produce new evidence and the decision makers who use it, to renew our focus on achieving a high-value healthcare system that meets the needs of all Americans, especially those who may be at greatest risk from any changes to come. And in closing, as I've always wanted to say, I'd like to thank the Academy for this award.
What, no music? Congratulations, John, and thank you for your incredible contributions to both Academy Health and to the field. Now we will recognize the Alice S. Hirsch New Investigator Award winner, named for the founding executive director of our predecessor organization, the Association for Health Services Research. The Alice S. Hirsch New Investigator Award is presented to scholars who are new to the field of health services research and show exceptional promise for future contributions. Would like to thank Victor Monturi, the chair of the New Investigator Award Committee, and the other committee members. I am honored to present the 2017 New Investigator Award to Julia Adler-Milstein. Julia is internationally recognized as a leading scholar working in the issues of healthcare information technology and its intersection with both policy and management. Julia will join the University of California, San Francisco this summer to become an associate professor in the Division of Hospital Medicine and to launch a new center called CLEAR, the Center for Clinical Informatic and Improvement Research. She is currently an associate professor with tenure at the University of Michigan, jointly appointed in the School of Information and the School of Public Health. She received her PhD in health policy from Harvard University in 2011 and received Academy Health's Outstanding Dissertation Award for her doctoral research. Since joining the University of Michigan, Julia has received 4 prestigious awards, including 2 national awards that recognize outstanding junior faculty. Julia's substantive area, how health IT can be used to drive gains in quality and efficiency, has taken a multifaceted approach to answering the most pressing policy questions using robust methods. As a new investigator, she has produced an influential body of high-quality, policy-oriented work. Julia, congratulations. Let us celebrate her as she comes forward.
Thank you, Dr. Gaskin, and thank you, Academy Health, for this wonderful recognition. Each year I look forward to this meeting, the annual research meeting, where I feel part of a vibrant community of scholars, and I give more hugs than handshakes. It's particularly special to receive this award, given my admiration for past winners. many of whom I'm fortunate to have as colleagues, mentors, and friends. It's also special because it recognizes my passion, research. I feel so lucky to do work that I find deeply meaningful and interesting, and that has an impact on policy and practice. For that, I have 4 key people to thank. First and foremost is Ashish Jha, who's an incredible researcher and a just all-around wonderful person. I've learned so much from him, and I feel so lucky to have had you as a mentor over the past decade. Being a good mentor takes time, thought, and willingness to give honest feedback, which is hard to do. Ashish, you got an A+ on all 3. You set the mentorship bar incredibly high. Thank you. Next are my parents, who are here today. My parents have always been totally supportive without pushing me in any particular direction, which is a notable feat for Jewish parents. So thank you, Mom and Dad, for everything. And last but not least is my husband, Ariel, who's home with our daughter, Gabby, and is just an essential pillar of support for me day in, day out. There are many more people I want to acknowledge. From my time at Harvard, Joe Newhouse, David Bates, and my peers in the PhD program in health policy. From my time at Michigan, John Ianian, Andy Ryan, and my awesome students, who I know are down here. And from UCSF, where I'm heading for my next chapter, Bob Wachter and Claire Brindis. Thank you to all of you. Receiving this award led me to reflect on how my career has evolved since I started in the field, and what I wish I'd done earlier. It's only over the last few years that I've spent time on the Hill and with a variety of federal policymakers to help translate my research into policy actions. Doing so has been extremely helpful and arguably essential to ensuring that my research has an impact. A key reason I didn't do this early on in my career is that I simply didn't know how, but it turns out that doing so is quite easy. It can be as simple as calling to ask your representative or a representative on a committee that's working on relevant issues to set up a meeting, and they actually are set up to do this. They welcome your calls. Or as suggested by Andy Beinman, aligning yourself with an advocacy group in a relevant area to yours and working to ensure that they know about what you're studying and finding. Although I was intimidated at first, I shouldn't have been. I found that congressional staffers and those working in federal agencies are eager to learn about research and welcome the outreach. And this has continued to be true, even over the past 6 months. So I'd urge you, particularly those of you early in your careers, and particularly at this moment in time in our country, not to shy away from working to close the gap between policy research and policy. Thank you so much for this award. It's really wonderful.
Congratulations, Julia. I would also like to recognize some additional award winners. Congratulations to the Article of the Year Award winner, Laura Worry, the Outstanding Dissertation Award winner, Rebecca Haffagee, and the Best Student Poster winner, John Richardson. Congratulations to all of our award winners. Before I adjourn the recognition portion of this plenary session, I want to announce that Dr. Eric Larson, Vice President, Research and Healthcare Innovation, Kaiser Foundation Health Plan of Washington, and Executive Director and Senior Investigator, Kaiser Permanente Washington Health Research Institute, will chair the 2018 Annual Research Meeting, which will be held on June 24th through the 26th in Seattle, and we hope to see you all there. So please join me in a round of applause for all of our wonderful researchers. And now, Lisa.
So we should have brought the music on. No. Moving right along, the second portion of today's plenary is a wonderful panel, and it is my pleasure to just introduce the chair and let her introduce her colleagues. The panel is entitled "The Role of Resiliency in Communities and Healthcare Systems," and we are very fortunate to have a very talented panel moderated by Dr. Karen DeSalvo. Dr. DeSalvo, if you don't know her, is a physician who has focused her career towards improving the health of all people with a particular focus on vulnerable populations. She has done this through direct patient care, medical education, policy and administrative roles, research, and public service. Dr. DeSalvo most recently served as the Acting Assistant Secretary for Health at the U.S. Department of Health and Human Services and as the National Coordinator for Health Information Technology at HHS. But she is close to home here. Before joining HHS, she was Health Commissioner for the City of New Orleans and Senior Health Policy Advisor to the New Orleans Mayor from 2011 to 2014. So, thank you, Dr. DeSalvo, and over to you.
Wonderful. Well, good afternoon, everybody. How y'all feeling? You're in the South, you have to respond when I say, how are you? That's true. Excellent. Well, I'm just delighted to have the opportunity to moderate this panel of really extraordinary women and leaders in our country. And I'll have the chance to introduce them in a moment, but I just wanted to make sure you knew a little bit about the frame of our conversation, which is really to talk about the role of resiliency and preparedness in seeing that we can help communities respond better to disasters and do that in a way that attends to those who are most vulnerable in our communities. This is certainly a lesson that we learned well here in Louisiana, and I think are still attempting to shore up our infrastructure, that it's not just about the response, but making certain that in the everyday of people's lives that we're attending not only to their healthcare needs, but to their underlying social determinants of health, and that we're thinking of leveraging technology and tools in ways that can really create an infrastructure that supports them in disaster and in every day. What we're going to do is I'm going to introduce our panelists, and I'm going to ask them to make some opening comments. We'll go into some questions, and we've hopefully been able to reserve some time at the end of this for you all to come up and ask them some questions. I'm going to start with Herminia Palacio, the Honorable, I think is what I should call you, who is currently the Deputy Mayor of Health and Human Services in New York. And in addition to her responsibilities over the Department of Public Health and the New York hospital system, she also has an array of responsibilities that relate to less potentially happy things like the coroner's office as one example in domestic violence. And she was the public health commissioner in Harris County in Houston at the time of Katrina, and amongst the many things that she did, she saw that some 27,000 people had access to the care and supports that they needed. So on behalf of my community, I say thank you to you, Harminia. Next, I want to introduce Anita Chandra. Anita is with us today as the director of the RAND Justice Infrastructure and Environment Institute. In addition to the work that she's done on thinking of the underlying social determinants, civic engagement, the need for broad planning, looking at disparities across populations, she's also been very active in the space of metrics development, so we can actually understand if we're making a difference in people's lives, and then particularly with the National Health Security Strategy. And then it's nice to also be up on the stage with Nikki Lurie, who is an old friend and was a colleague when we were at HHS. She was Assistant Secretary for Preparedness and Response, and in fact was in that role when I was Health Commissioner, and we had a project that we did together, which I hope you'll talk about, Empower. But currently, Nikki is serving as the Acting Deputy Director for Quality Healthcare at the Indian Health Service, an entity that is really trying to reshape itself, and of course a very well-known health services researcher in her own right. So with that, I want to turn it over to you, Herminia, just ask if you want to make some opening comments about this big frame about resiliency and how we can do a better job of helping communities to be prepared and respond as appropriate.
Great. Well, good afternoon. Thank you, Karen. It is quite an honor and a privilege to be up here on the stage with with colleagues, friends, and incredibly dynamic, sharp, smart women. So I feel quite, I don't know about honored, but honorable, but I'm quite honored to be here. So, you know, our shared experience with me on the receiving end, only on the receiving end, and I think that's really an important distinction, at least for Hurricane Katrina. You know, Houston has been in the eye on other hurricanes, but for that. on the receiving end of, we ended up triaging 65,000 people and housing 27,000 people. And when you talk about disasters, I think if there's one thing I would like people to go home with today, it's to never again let pass from your lips that disasters are equal opportunity events. I want to dispel that myth, because disasters are not equal opportunity. They, in fact, amplify, in many cases, amplify everything that was wrong with society before the disaster hit. And Hurricane Katrina was a prime example. And it was an incredible sorting mechanism where people who had the means and the opportunity to heed the warnings and flee ahead of the storm were able to do so. And people who were left behind weren't left behind just because they were recalcitrant. Many were left behind because they absolutely didn't have the means to get out ahead of time. We saw that very clearly. But it's not just natural disasters like hurricanes that affect us. Very recently, the world saw an emerging infection with Zika virus. It's very clear that Zika virus has, again, disproportionately affected the nation. But even in a city like New York City, as we were preparing for Zika virus, which thankfully knocked some vinyl, we did not have local distribution, but we had many women who were affected with Zika during pregnancy through travel. And again, not an equal opportunity event, because affluent New Yorkers who traveled to resorts weren't the people that we were seeing with high rates of Zika virus and travel-associated infection. Who we were seeing was women who came from the Caribbean or from South America, who were not going to travel to air-conditioned, lovely hotels, but were going to visit mom and dad, going to visit siblings, going to hang out in non-air-conditioned environments. And we have Zika-infected babies with neurological sequelae in New York City. 48% of the Zika-infected women were from the Dominican Republic. Not an equal opportunity infection. Hurricane Katrina, not an equal opportunity disaster. And so as we think about resiliency, and as we think about applying the principles of equity, both in advance and during a disaster, I think it's really incumbent on us to think about what are the metrics, how do we target resources that we may need to target disproportionately just to try to level the playing field and get people a better chance of surviving whatever disaster happens to be afoot. So I think I'll just leave it at that.
Great, thank you so much. Well, I couldn't agree more, and I really appreciate your comments. You know, I'm going to take a page out of the VUCA and the hope paradigm. I feel I have both today. But the thing to keep in mind, which is, I think, builds on what Herminia is saying about it's not an equal opportunity sort of offender in terms of vulnerabilities, is that what resilience provides us is a lens by which we can look at complexity, which I think is the C, right, in VUCA, and look at opportunity. And over the last 10 plus years, resilience and the preparedness and response and recovery discussion, I think allowed some communities to come together in really important and critical ways. One was to think differently about how we design and consider community assets and vulnerabilities. It brought together public health and health services research into focus with emergency management to really understand some of those deep and long-standing deficits that we have allowed in our communities to thrive and flourish, not the things that we want to thrive and flourish, and to really be honest about social drivers of health. We've been able to have a conversation about the continuum of risk that many of our families and households and individuals live on, quite frankly. We were able to have a conversation about what is really driving acute and chronic stress. So the hurricane might come, the tornado might come, the flood might come, but we know that our households, our families, our colleagues, and our peers are living day to day, in many cases, on a risk continuum. So how do we talk about that? And we've been able to have a conversation also about some of those emerging risks. We just heard about Zika, but as we talk about slow-moving disasters, community violence that is entrenched in certain neighborhoods and communities, chronic poverty, and climate, as we think about the social justice and equity issues around that disaster. How do we start to bring in hospitals, healthcare institutions, other health service providers into the conversation? So there's great promise of what the last 10 years has provided us, because we've been able to have a more holistic and systems approach to the conversation. I think we'll talk in a little bit about where we can go and where we can see opportunity given the current landscape. But those are sort of the poignant points that moved us from a classic preparedness hierarchical model of how we respond and recover to how we actually think about a fuller appreciation of community. And I remain hopeful, I guess as part of your other hope, about the innovations that have been left in communities, regardless of what sort of transitions are happening at the federal level. So that's kind of my state of the state on resilience preparedness at this point.
Thanks, Anita. Nikki?
Great, thanks. And it's great to be able to build off these terrific comments. And, you know, having just come off of 8 years of leading HHS through all kinds of crises, hurricanes, floods, tornadoes, infectious diseases, environmental catastrophes, whether it's deep water or Flint, or mass shootings and mass violence, as Anita talked about. They're all different kinds of crises. But one of the things that unifies them all really is this concept of resilience, and it's really important. And I think for this audience, I really want to focus, I think, on 5 points about resilience, or 5 aspects of resilience. You know, first, just to remember that individuals and communities that are more healthy and more resilient are going to do better in any disaster. And people ultimately judge any disaster and how bad it is by how well the community recovers. So that piece about resilience becomes really, really important. So first element of this is about healthy people, right? People who are healthier are going to do better. It's not an equal opportunity employer. You got to be healthy to be able to get out of harm's way, right? You got to be healthy to even have the wherewithal to take your medicine with you if you're sick, or to do whatever. But in order to be healthy, you not only need access to care, which we've been talking a lot about, but you need a community design that's going to help you be healthy. And that's something that we haven't talked that much about yet today, and I think that we need to, and I'll come full circle to that. The second thing is that every single crisis and disaster that I have been involved in has gigantic behavioral health implications, both for the population that's affected and for the responders themselves. We saw that and came to clarity about that, I think, during Katrina, but it has been a recurrent theme. We know almost nothing about how to prevent those behavioral health sequelae for crisis. We have a behavioral health model in this country that treats people one person at a time. We don't know how to do the prevention piece, and we don't have good models for the how do you treat a community's behavioral health or mental health during or after disaster, a place that you can help. Related to that is a concept that Anita works a lot on, as do many of us, and that's this issue about social capital. If we're really serious about resilient people and resilient communities, we need to do something about social capital. What we know from disaster research is that people who are more connected to one another and whose connected groups are also connected to an effective institution do far better than the people who lack those connections. Talk about an equal opportunity or unequal opportunity disaster. Even people who have few assets, if they have this good social connectedness and they're connected to other people, do far better in a disaster. So as we're talking about building healthy communities, we are talking about building communities and that community connectedness. I would be remiss if I didn't talk about health system resilience, because it is huge. And while I think that probably building social connectedness might trump getting your generator out of the basement, I wouldn't want to have to pit one against another. Healthcare facilities need to be able to plan to stay open. If they go down, get open, and be sure that their staff can come to work and take care of people who need them. Electronic health records have been huge in this regard if they're accessible, and that means you have to have failover remotely hosted records, and we can talk a lot about IT and EHR policy that will support all of these things. You need to think about the whole system, like hopefully we're all here to do. It's not just about a hospital, but it's about the whole healthcare system in the community, whether it's the nursing home, whether it's the adult care home, whether it's the dialysis facility. All of those pieces are working together. What is the role of pharmacies? During Hurricane Sandy, we took care of thousands and thousands and thousands of people from adult homes and group homes and nursing homes, in armories and mass shelters all over the place, only because of poor planning, mind you. This is, I think, where special populations and most vulnerable, unequal opportunity populations come into play. It should never have been a surprise that 40% of people during Hurricane Katrina had chronic disease and were vulnerable. We should have known it because data and health services research should have helped us get there. Again, gets to all of you. Through a lot of work now, it is no longer a surprise. We have worked really in wonderful ways with some of our other data partners to be sure that doesn't happen. So the project Karen is alluding to leverages data from Medicare to tell us where are all the electricity-dependent people in the country, for example. Because you know what? When the power goes out, they get in trouble. And so we now can think about CMS as a first responder. Within 2 hours, they can have the names and addresses of people who are electricity dependent to a health department, as they did with Rebecca G. during recent crises in New Orleans. CVS Pharmacy texts or robocalls everybody in the eye of a storm or reminds them to pick up their medicine in advance. So using data and health services thinking to save lives. And then finally, recovery. We can't forget about this role of resilience in recovery. And recovery is a period in which there is incredible opportunity to think about what are the hopes and dreams that a community had for itself. If it has an opportunity to rebuild, how does it want to do it? How does it rebuild so that it rebuilds with social determinants in mind? How does it rebuild so it rebuilds with social connectedness in mind? And how does it take that influx of recovery money to really build healthy communities to leave people better off than when they started? That's the hope part. Not so sure about the VUCA part. That must be during the disaster itself. We can talk all about that, but I'll stop there.
That pretty much defines disaster. Well, thank you all very much. There's a lot packed into what you said, and we have some questions to tease it out a little bit. One of the places I wanted to start was about this partnership between healthcare and public health. And you know, as we experience the passage and changes from the Affordable Care Act, I think one of the unexpected or maybe unintended sequelae was that as public health in many parts of the country got out of the business of direct clinical care, as people became insured, health departments had fewer and fewer clinical staff available to staff shelters or to handle some of the response components, much less some of the needs in between the disasters, God forbid, to help identify high-risk populations and develop relationships with people who had medical special needs. So I wanted to start with Anita, but ask you all to respond to this sort of new world of change again, and what you see as some of the potential consequences of us changing the way we pay for care, the kinds of coverage that we have, but also not only how the healthcare system may be impacted by that kind of a big policy change and financial change, but also public health, and what are the sorts of big issues that this group should be thinking about to be looking for on the horizon from impact and to help mitigate against that.
I'll start and please jump in. So, I mean, as we talk about that holistic health system that Nikki referenced, there are sort of critical parts of that system that are especially necessary in disaster response, but really in terms of recovery and long-term recovery. Nikki referenced the sort of mental health and behavioral aspects of recovery. So many people estimate, although there's not really great data out there, that it's 3 to 4 times as long to recover mentally or sort of spiritually and emotionally from any one disaster as it is to kind of rebound and respond in a kind of a physical health and an infrastructure way. Well, take that into account when you ponder that the scope and scale of disasters has changed and we have overlapping disasters. That's the world we live in. So we're never really out of a disaster cycle. Some are more acute than others, but everybody is sort of living on that continuum. So when you shred or perhaps have places that are not going to get as well funded in terms of behavioral health, in terms of clinical care services, in terms of coordination amongst the arms of activity, so public health, social services, and traditional healthcare, that raises challenges about the ability to respond, particularly in long-term recovery. You also worry a little bit about changes that affect the ability of the workforce to keep up core skills, capabilities, and competencies, whether it's in a public health department, in a hospital or a healthcare system, or in supporting ancillary or social service or related agencies. The promise of the resilience and preparedness, response, and recovery conversation over the last few years was that it, as I said, brought into focus some of those conversations around social drivers in a new way. And anything that sort of limits or perhaps disentangles that coordination and that linkage definitely sets us at risk potentially in the future. So those are the things that I'm sort of looking towards as we ponder looming not just Medicaid cuts, but other aspects that are in the proposed bill that would create greater fragmentation when we were working towards a more holistic strategy.
So I'm building on a couple of the comments, both by Nikki, and calling attention to the behavioral health aspects. And I loved your sort of making the distinction between individual health and sort of the public health approach to community mental health, which is critically important. I do want to elucidate that not only do we have a changing environment around healthcare policy, but we really have a very frightening environment around immigration policy. And if you're talking about whole-scale community anxiety and fear around the rhetoric, not all of which is grounded just in rhetoric, right? There are, in fact, significant policies being put afoot, not just around immigration status, but around keeping people out of healthcare systems, keeping people out of social welfare systems for fear of public charge. So I think we really need to, as health policy researchers and academics, to really start to understand and try to hone in on how do these fears really alter behavior? How do they alter people coming in and out of the very systems that we are setting in place to try to build that resilience in advance? And if we have people who we don't even know exist because they're no longer coming forward for the services in the systems that we might have, how do we protect them in an emerging disaster? So I think it's really, in terms of VUCA, in terms of the complexity here. And I would also say, I think, the thinking about behavioral mental health on a population scale in terms of messaging. I think we've all had the opportunity to understand the power of a message well delivered and to understand the chaos of a message poorly delivered. And I would urge the researchers to really start to, to work with some of the communications in the communications world, because I think in terms of implementing sound messages to address that sort of population health both before and after, I think is critically important, and I'm not sure that we have the data that we need to inform that kind of crafting.
Or maybe we're also not leveraging the technology that we need to customize that.
So I might comment that I got into the field of preparedness right after 9/11 and anthrax. And when we looked at this country and we said, how could we have allowed this to happen? what we realized is we had about a quarter of a century or more of systemic disinvestment in public health. So if you're public, you have to respond with the system you have in hand. If your system is rickety, it's going to be rickety and a disaster. If your emergency rooms are so jammed that they can't surge, you're going to be in trouble. If you can't do surveillance, you're not going to find what's going on. And so we built back and we made preparedness part of public health until the last couple of years. And now we have had again, and are facing a huge cliff with another really big systemic disinvestment in public health that fragments and weakens our surveillance systems. It changes the entire workforce in terms of people who think they have a career in public health and will work in this field, and it limits our ability to take care of the populations Erminia just talked about. I spent the last year of my term running the federal response to Flint, and then working on Zika. And both of those were incredible examples for me of what happens if you cut public health funding. If you cut public health, you can get away with it for a year. Maybe you can get away with it for 2 years or 3 years. But you know what? It comes back to bite you in terrible, terrible ways. It comes back because you missed a whole community of lead-poisoned kids. It comes back to you because you can't do surveillance for Zika in Puerto Rico. It comes back to you because you have totally dismantled the systems that we all count on for our populations and for ourselves to be healthy.
Or because you don't have the bandwidth to do health and all policies and be at the table to prevent lead contamination in the water in the first place. But it does raise, I think, especially the Flint example crystallizes, I think, for a lot of people, the opportunity for a partnership between the healthcare system and public health. And I think the partnerships just begin there, that there are so many other systems that you all have alluded to. So I sort of want to put this question out in a couple of directions and have you all pick up whichever ball you want. One is, especially in this world of resilience and recovery, at the local and state and federal level, I think we've learned that the traditional partners that were available to respond are necessary but not sufficient, and that it takes different and additional partners at the table, whether that's to support language access or opening gas stations, right? So I'd love to hear your thoughts about how response resiliency work is evolving to have a bigger tent, a bigger table, to be more inclusive, and who the key partners are outside of public health and medicine. And I want to add on to that to see if you could say some words about how we leverage the new world of whether that's simply social media or artificial intelligence, some digital tools that we now have available, and if there are some opportunities for us to be smarter about helping communities be prepared and helping them respond. So you can pick up any of that y'all want. Go ahead.
Do you want to start, and then I'll go after that? Yeah.
Yeah. I mean, first of all, I think just the conversations about the divide between public health and healthcare delivery or health services researchers, I think fundamentally just have to stop, because that's a weird dichotomy. And I'm a public health researcher, so I have to say that. And that, I think, comes through in the last 10 years of resilience research and how we talk with, collaborate, convene, organize the terminology and the conversations that we're able to have. But then it absolutely, to Karen, your point about health and all policies, people have heard Robert Wood Johnson Foundation's culture of health. Who we have in the conversation has to be fundamentally different. And what resilience allowed was not just that we brought environmental activists to the table, infrastructure and urban planners, transportation leaders, mayor staff, faith-based community, and the like to the table, but that the power and influence discussion and who was a decision maker in that conversation fundamentally had to change. So it is not enough to sort of factor in those perspectives. It is all about sort of the governance and decision-making framework of how we do our business. And it's a sort of a losing battle when we do it in a fragmented and siloed way. And above and beyond the humanitarian aspects of it, it is going to spend down every last shred of money that we have, just based on the risk profile that we are dealing with as a country and as a world. So I think we were able to forge those conversations and that dialogue and those partnerships in unique ways. And the question for us is how to continue and sustain those, incent those partnerships, create those collaborative models, train our new workforce, think differently about our schools of public health and medical schools. That's what's going to be our legacy, regardless of sort of the political climate in which we live. But we have a foundation upon which to build. So that's what keeps me hopeful about innovation and creativity at a time of crisis. But it is going to require us to reshape our paradigms a little bit more than we probably have been comfortable with in the past. Romania?
Yeah, so I think one of the things that we haven't discussed is really the differing natures of our federated system, right? So some of this really happens at a local level. Some of the responsibilities are state, some of the responsibilities are federal. I've been a local gal, but I've been a local gal in, in California and in San Francisco, where the public health enterprise was very well funded, and in New York as well. And I've been a local gal in Harris County in Texas that was, I call it a sort of regulation-free zone, and where things weren't well funded. And so the nature of the partnerships and the caliber of the partnerships can really fluctuate. Mm-hmm. And I think it is important to be very attentive to the audience. I think it's important to have a menu of ways in which we can think about what's the best way to bring people to the table. And I think just like I would say the practice of medicine really involves practice, right? There's data around volume and who's good. There is a certain element to the practice of preparedness.
Then we're really good at it. Sorry, Rebecca.
And how we start to sort of bring those partnerships together to practice, because I think that not only does that consolidate relationships, but that actually does start to build a resilience that's beyond the individuals, because some of those partnerships need to be clearly institutional and go beyond the individual relationships.
So this is, and Nikki, I want to go to you in a minute, but can I ask you to try to weave in something, build on what Herminia just said, which is that, when, for us in Louisiana, when Katrina hit, we had been practicing around bioterrorism and how to mitigate against white powders, right, as opposed to a flood, which is essentially what happened. And the same story happened when we had a wind event, and we're more prepared for flood than for wind and powder outage. So just in the frame of partnerships, but also I think if I could ask you to talk a little bit about the policy environment and how you think that has evolved in the last 8 years. To kind of create this kind of more broad partnership model, but also an all hazards approach, and where you think that we ought to be going at the federal, state, and local level to be more prepared.
Great question. And I don't think we can do any of this without a partnership model. Mm-hmm. It's really clear, there's this old adage that you never want to exchange business cards in the middle of a disaster. So the practice of preparedness is also about the practice of building these partnerships and about building these collaborations. It turns out that in any one of these disasters, about 80% of what you need to do is the same, regardless of whether it's a flood, a tornado, an environmental disaster, a terrorist attack, whatever. So you better be able to do those fundamentals. You better be able to do them well. You better be able to do agile. I ran an organization that was supposed to develop medical countermeasures for bioterrorism. You know what? It turns out that Mother Nature is a terrific bioterrorist. So we were able to build an infrastructure that not only worried about making anthrax vaccine, but that could make a pandemic flu vaccine or a Ebola vaccine or a Zika vaccine. And we have to think in a much more flexible and nimble way as we talk about the all hazards partnerships. But again, I think that for me, Flint was really the crucible of where a lot of this preparedness practice came together, because the response, first of all, was community driven, and it was driven by what the community told us it needed. And I'll say recovery from Hurricane Sandy was the same way. But who were the partners that came to the table? Yes, it was the healthcare system, it was hospitals and doctors. And yes, we decided that we needed to do a substantial Medicaid expansion to take care of all the kids and families that might have been lead exposed. But we also understood that these kids couldn't have a healthy future unless we did some other things. Did early preschool brain development, so there's now universal preschool in Flint, until we took care of nutritional needs, because there was no supermarket there. So the Department of Education, the US Department of Agriculture, and the state components came to the table. Unless there was healthy housing, HUD was at the table. These are the preparedness practice partnerships that help you be ready and then help you build back better in a much more holistic way. So it all gets back to this issue about social determinants. It all gets back to this issue about culture of health. And it all gets back to the day-to-day system. You have to do that. So when something bad happens, you're ready. And when something bad happens, never let a good disaster go to waste. Use that opportunity to bring everybody together to innovate and do better than you had before.
We can just do better in the everyday. If you all have questions and want to start working your way to the microphone, the panel would welcome them.
You know, while people are coming up to the mic, I think one of the things that you're hearing is a theme emerge that resiliency day to day, right? So community health day to day. So the things that we are doing as on the equity front, on the quality of care front, on the built environment front, we may not have a sort of disaster lens as we're doing that work, but it really sets a foundation for a robust response.
Couldn't agree more, and I would just add data and information.
Absolutely.
And connectivity to that. There's so much opportunity that I think we have in that space, and we certainly strove for that in
And maybe after some questions, I might want to come back and talk a little bit about data and what you all as researchers might be able to do and contribute to this space.
Data. Information is actually what we need. Yeah. Why don't you start?
My name is Mariel McCollum. I'm a PhD nursing student from UNC. So as climate-related events and disasters continue to increase in frequency, we know that hospitals are increasingly going to have to respond to these. For example, evacuating before or during a hurricane, or sheltering in place during a tornado. However, there are currently no requirements for reporting details about these evacuations, and there's no kind of central database to aggregate all this information. So we're lacking really important data about hospital disaster response that we could be using to better anticipate risks and needs and prepare hospitals and healthcare organizations to respond to disasters. So my question is, how do we start putting structures in place to capture this data about all these responses that hospitals are going through, so that we can start better preparing hospitals to be resilient?
Great question. Nikki?
I'll take that. I think it's a terrific question. And I think the first thing that you point out and that Armenia points out is that not all of these disasters become big national events. A lot of them are local and small-ish, but they're real, and there's still an important opportunity to learn from them. So I'm pretty much of a data geek, and this is a thing that was really, really bugging me during much of the time that I was in this role. And there were a couple of things that we started that I would love to see the health services community, ARC and others advocate for and move forward. You can't do much without data. You can't ask health services researchers, all of you, to generate information for us without data. But so after Hurricane Sandy, actually we convinced the department that we should use, 100% of the money in the emergency supplemental to start building data sets in a research community. So at the end of the day, you link all the data from the delivery system on what people use in Medicare and Medicaid and private claims data. with data from FEMA, with data from the mental health system, with data from HUD, with data from the census, and you put it out for people to be able to explore. And we ought to be doing that and start doing that with every disaster so that you can compare across disasters, that you can learn from them, you can look at a community response, see what went well, see what didn't, see what happened in different hospitals, and really answer these questions scientifically. So that's one piece of it. The other part of it is that there's tremendous opportunity when something happens to be ready in data collection mode. That means you have to, I call this now science preparedness, right? And you have to be ready with a team, with protocols, with IRB approval, with all of these stuff, so that you are out doing stuff in real time. And both of those things have to go hand in hand.
Thank you, Nikki. I'm going to go to 4. I want to take a moderator's prerogative and just add a little onto your question, or just to underline a word that you used, which was about resilience. And I think a lot of times we think about disaster response and how folks are responding, and that was embedded in your question. But the resilience part is, I would submit, a much more unknown field, more opportunity in that space to really understand the key ingredients for success and or failure, and so we can try to replicate models going forward. And it's going to become more important as we have fewer resources at the local level. I'm going to go to 4 and then to 2.
Okay, hi, I'm Betty Beckemeyer. I'm at the University of Washington in Seattle, and I'm a public health systems researcher. So I want to first thank you for this tremendous panel. I think all of us here who are public health systems researchers are very grateful. Yes, thank you. And I have a two-part question, and one is, and I think Dr. Lurie, you just kind of touched on it a bit and gave a bit of a response, but maybe the rest of you have something to add. And that is that what you're really talking about is also shoring up that rickety public health systems research field, which, you know, talk about rickety infrastructure, that's what our field is as well. And so where to, and especially in this environment, really have where do we get, you know, your concrete ideas about where to get the resources for that kind of super important research. We have our own, but I'd love to hear more from you. And then secondly, you've touched on the nature of these silos between health services research and public health systems research, and breaking those down, you know, some of concrete ideas about how to better do that. Thank you very much.
Great. Any one of y'all want to start? Want to start?
Oh, sure.
Yeah.
Well, first of all, on the resilience, kind of the capacities and capabilities and the metrics, and I think it goes to the kind of rickety public health system. We know more now, certainly, about what those capacities and capabilities are that we should be tracking. But one of the things that's interesting is the extent to which our data systems are actually supporting the kinds of indices that are going to give us the best signal on resilience, and kind of getting rid and shedding a lot of, in some ways, useless data. And I think that's sort of a process that we've been engaging on probably the last several years, but how do we now think about that going forward? You know, there's a real opportunity with a focus on open data platforms and data democratization and new data coming from everything from sensors and surveillance to citizen science, to really think differently about how we shore up public health system capabilities to track interesting data sources and kind of information really on capabilities and competencies. Because you're never really going to be able to predict the black swan or anything else that's coming down the pike. All you can do is really shore up those proxy capacities and capabilities. To the question about, it's certainly a personal interest for me in terms of this, what I would say, artificial divide between health services research and public health research and population health, and we've got to kind of push past it in terms of a holistic health and starting to think about what we fundamentally value in terms of health and well-being, and then what are the pathways to get us to health and well-being. Those are the conversations, quite frankly, that need to happen in a de-siloed way. They need to happen in how we form our teams, they need to happen in terms of how we form our policies, and they certainly need to happen in undergraduate and graduate programs. And I think there's inching forward, but not a full transformational moment disruption. in some of the ways that we educate and train. But I think it's all in our responsibility and all in our opportunity, quite frankly, to have that moment, and quite frankly, to capitalize on the moment that we're in right now.
So, so some of you saw me at the microphone yesterday at the end of the plenary session, unable to ask a question. So I might reframe it as a comment now. It was intended as a question for Daisy and others, but so an observation that I would make in general, we all know that there are a lot of factors that impact on health. But when it comes, at least at a federal level and often at a state level, to making policy, doing budget scoring, looking at the savings that accrue or the improvements that accrue to health from other social policies, you can never get there. 2 decades ago, Victor Fuchs showed us all that if you cleaned up the air, got rid of particulates in the air, you would decrease Medicare expenditures by 7%, just as an example. But the way our public policy is put together, you can't say, gosh, if I invest in controlling air pollution, I'm going to save money in the healthcare system. It's a really big structural disconnect that at every level keeps us from getting to where we all want to get to in investing in the kinds of policies, programs, other things that ultimately pay the dividends to health and will reduce long-term healthcare costs.
Yeah, you know, while we're on the data, on the really heavy in data, I want to make a distinction because I really appreciated the question thinking about public health systems research, and I love your, you know, we've got to break past the barrier, but we also need to think about data and information in sort of 2 distinct buckets, right? There is data that one needs for management purposes, and in the middle of a disaster, what we need first and foremost is that surge capacity to really understand what's going on and to use that data to manage the capacity. And I would say that there's a dearth. Some organizations, you know, I've got, as you mentioned, Department of Health and Mental Hygiene in New York, you know, we've got some organizations that have deep data capacity, but those jurisdictions are few and far between, right? The other jurisdictions really need to rely on sort of researchers who live outside of the governmental space to help provide that data for data management's sake. And having been on both sides of the sort of health services researcher side and the public health side, I would also urge us to gently resist the temptation to, in the middle of a disaster, leap into that other bucket of data, which is critically important, but think about timing, which is how do we inform systems for learnings later on? Because the folks who are on the ground trying to respond to the disaster don't have the bandwidth to think about those broader questions, and in fact really critically need some surge in data capabilities in the here and now. And I don't think that that those are distinctions around who's doing the research, but I think it's a way of thinking about what is the object of the data collection.
That's great. All right, we have 2 more questions in about 7 minutes, so I'm going to go over here to number 2.
Jack Needleman, UCLA School of Public Health. I want to shift from the data, as much of a data geek as I am, to talking about other kinds of resources, physical resources and personnel. A lot of us have spent the last 2 days in sessions talking about the triple aim with a particular focus on the value and efficiency aim. And an awful lot of the work to create efficiency in the healthcare system has involved leaning it up, doing more with fewer resources or more with less resources, with the same resources. Yet, when I hear you talk about resilience of the system and dealing with disasters, I hear you talk about surge capacity, which to me means redundancy and slack. So we've got one set of pressures on the system to lean it up to reduce costs, and I hear you talking about the need for redundancy and slack in order to have surge capacity for when we need it. And I'd like the panel to talk about how we resolve those 2 tensions or pressures or needs of the system.
So I'll take a quick stab I would reframe surge as redundancy and slack.
Yes.
So, you know, I would love to have worked in an environment where I had the luxury of either redundancy or a lot of slack. I think that there were times, you know, where we were more robust, and that's about as good as we can get. I think surge can be about redeployment, right? It can be about shifting resources from a less critical or not immediately time-pressing kind of event and redeploying to something else, because I think it's probably unrealistic in the current environment that we're going to get to a redundancy and slack. So how do we think about redeployment in incredible ways?
So I too would want us to reframe it. I think that there used to be some concepts of surge that were things like, well, you could just go open a vacant wing of your hospital, or have a stash of something over here or something people over there. It never, ever works to have something that's not being used that you think you can dust off, stand up, and make work in the middle of an emergency. You are stuck with the day-to-day system that you have in hand. And so you have to look at that day-to-day system. You have to have thought about who are you going to deploy differently? How are you going to do just-in-time training? How are you going to triage in order to do that surge and redundancy? And how do you look at your processes so that you really are efficient in this? I don't actually for a moment think that disaster preparedness, surge, and lean are inconsistent. What I do want to think, though, is that if you are able to reap some savings, that you can reinvest those savings into the conditions that are going to create health, the conditions that are going to create better preparedness.
You know, I think there's a lot. I want to unpack a couple of things, and I want to be unapologetic about surge capacity. So first, there's a pretty big difference about what you need for staffing up in emergency. And in fact, it even matters because in the disaster response, depending on the declaration, you're able to pay your staff for overtime. So the opportunity there to have people come to the table or have contracts you extend to clinical service providers is real and exists. But in that period of recovery and then moving into resilience, that is when there are little to no resources to be supportive, and you're relying on you know, 2 nickels and some friends to get the community together. That's why when it becomes, frankly, really important in a run up to any disaster that you already have exchanged business cards, the Senator Collins quote, and personally experienced that. But those are relationships that you can leverage. But on the other hand, you have an expectation as a citizen in this country that public health is going to save your life today, not only in the general everyday, but in disaster. And that means that when the smoke rises or the water rises or whatever is afflicting your health, the person who's most likely to knock on your door is going to be somebody from a public entity, public health and otherwise. And so I think as a country, I would just be stronger and say, I think it's okay to have some surge capacity, because it's not the responsibility of private entities. So you don't always want to completely lean up the system.
Thank
So
you.
with that monologue, I'm going to go to Joe.
Joe Thompson from Arkansas. I want to just emphasize, it's not just having the index cards or the business cards, it's having that cell phone number already in your phone, so that when it hits, you're not looking for the business card. We were, I think, a supportive northern neighbor under Rita and Katrina, and had other local disasters that helped us work closely with the corporate sector and others to make things happen. As I was sitting here, this is kind of loud, as I was sitting here, I was thinking the one place that we do invest in preparedness are shiny red fire trucks.
Or what?
Shiny red fire trucks.
It's a kind of a sore subject in New Orleans.
Yes.
Well, they're different colors, but they're red. We put them in parades. We have people value them. But the reason they value them is not because we chose to tax ourselves. It's because the insurance industry requires the cities to have it in place in advance to get lower insurance rates. And I guess I just want to pose the question, is there a different business model we need to think about for aligning the incentives to be prepared for multiple different types of hazards like we do for fire?
So I don't know how many of you have been following the work of the National Academy's Roundtable on Resilience, but they've really tackled that head on in terms of insurance models, in terms of risk models, and also, frankly, in terms of the kinds of public policy incentives that get you there. So FEMA's flood insurance policies have changed dramatically. If you wanted to get recovery money after a flood or a disaster, you now have to build back not to the flood standard, but the flood standard, plus a foot. So both the strings now that come with the federal investments and the way the insurance industry is thinking about risk, whether it's for fires, whether it's the way hospitals are insured, whether it's the way communities are insured, is doing a better job at getting communities to at least hardwire the infrastructure better to fix your dams, to make sure your generators are not in the basement, to do all those things. So I think it's a really spot-on question. I just don't think it gets us all the way there.
So I'm going to close this out because we have just a few minutes left, and I'm sure the panel will be available afterwards if you have any additional questions. It sounds as though we've raised some pretty significant policy practice and research issues in the areas of funding, of intergovernmental relationships and partnerships, of the need to have the right infrastructure not only for response but recovery and resilience, for really critical issues about disparities in vulnerable populations that may get aggravated with existing policies. And I think also importantly, this issue of funding savings accrual from one system into another. And there are so many important ways that particularly the health economists can help. And I'll get to end on data. And it's really about actionable information and not just data, and building those bridges between your view on that and opportunity and what your response partners need in the moment will be a really critical motion going forward. So thank you to the panel.
Thank you.